Okay, so you know how sometimes you just dive deep into something, right? You get curious about, I don't know, like how a car engine works, or maybe the science behind baking the perfect loaf of sourdough.
Yeah, those rabbit holes.
Exactly. And then you find yourself wading through dense articles, YouTube videos. It can get overwhelming fast.
Oh, totally. Information overload for sure.
Well, that's kind of where we are today. You sent over a whole pile of stuff on local anesthetics used in dentistry, video transcripts, a big PDF. It's a lot,
Definitely comprehensive.
but also potentially headache-inducing. So think of this as your cheat sheet, your shortcut to understanding how that numbing stuff at the dentist actually works. We'll break it down, make it clear, and hopefully avoid any information hangovers.
Exactly. We'll pull out the key takeaways from all this material, the stuff you really need to know without getting bogged down in the nitty-gritty.
So we're talking about the two main texts, esters and amides, how they do their thing in the body, what makes them different, and even what's going on inside that tiny little cartridge they use.
Right, because even if you're not a dentist, this stuff is actually pretty relevant. It touches on some fundamental stuff about how medications work, how our bodies deal with them, and the importance of even those little extra ingredients.
No, not just fillers, right? They actually have a purpose.
Absolutely. And we'll uncover why those seemingly insignificant components can make a huge difference in how well the anesthetic works and how safe it is.
So, ready to demystify getting numb at the dentist?
Let's do it.
All right, so first things first, what do these local anesthetics actually do once they're injected?
Well, the material you sent highlights that most of them have a significant impact on our blood vessels. They cause them to dilate, which means they basically widen.
Okay, so picture those blood vessels getting a little bigger after the injection. Makes sense, right?
Yeah, it's a pretty common effect. But there's one very interesting exception.
Oh, right, cocaine. The
Mhm.
material specifically pointed out that cocaine is the only local anesthetic that consistently causes vasoconstriction, meaning it narrows those blood vessels.
It's a key distinction. And what's particularly fascinating is how cocaine achieves this. It essentially interferes with the body's natural cleanup crew for norepinephrine.
Norepinephrine, that rings a bell, but remind me what that is again.
So norepinephrine is a chemical messenger in your body, and one of its jobs is to tell blood vessels to constrict, to get narrower.
Okay, so it's like a natural squeezer for those blood vessels.
Exactly. Now, cocaine blocks the removal of norepinephrine, which means it builds up in the area around those blood vessels. And the more norepinephrine you have, the more those vessels constrict, leading to that prolonged narrowing effect.
Which is, of course, the opposite of what most other local anesthetics do.
Precisely. And this vasodilation, that widening of the blood vessels, has some significant consequences that the material really dives into.
Yeah, it's not just about those vessels getting bigger, it affects how the anesthetic behaves in the body, right?
Absolutely. So because of that vasodilation, the local anesthetic gets absorbed into your bloodstream more quickly.
Okay, so if it's being sucked up faster, it's not hanging around the injection site as long.
Right, which means the numbness might wear off sooner than you'd like. It can also mean less effective pain control because less of the drug is there to block those pain signals.
Got it. But there's also a safety concern linked to this quicker absorption, isn't there?
Yes, absolutely. The material explicitly mentions an increased risk of toxicity with vasodilation. When the anesthetic enters the bloodstream rapidly, the concentration levels in your system can spike, potentially leading to unwanted side effects.
Makes sense. It's all about keeping those levels in check. And speaking of where the drug goes, the material had a really interesting point about how local anesthetics get distributed throughout the body.
Yeah, once it's in the bloodstream, it doesn't just stay put, right?
Right. So I would have assumed that organs with a really rich blood supply would be a first places to get hit with high concentrations, like the brain, the heart, those kinds of vital organs.
That's logical, and it is true to a point. The material mentions highly perfused organs, those with a lot of blood vessels like the brain, heart, liver, kidneys, even the spleen. They do get high initial concentrations.
But then it throws in this curveball. It says that the greatest percentage of the local anesthetic ends up in skeletal muscle. That kind of surprised me.
It might seem counterintuitive at first, but it makes sense when you think about the sheer volume of skeletal muscle in the body.
Right. It's a massive amount of tissue compared to those individual organs.
Exactly.
Yeah.
So even though the concentration of anesthetic in muscle might be lower compared to those highly perfused organs early on, the sheer mass of muscle means it ends up holding the largest overall quantity. It's not just about how quickly the blood gets there, it's also about how much tissue there is to take it up.
Okay, that's a good now I get it moment.
Hmm.
So we've covered how local anesthetics enter the body and where they end up. Now, how does the body get rid of them?
That's where the key difference between our two main types, esters and amides, comes in. It's all about metabolism, how these drugs are broken down.
Right, the body's got to process them somehow.
Exactly. So let's start with the esters. The material explains that esters are metabolized relatively quickly, and this happens right in the plasma, which is the liquid part of your blood. There's an enzyme called pseudocholinesterase that does the job.
Okay, so they're broken down right there in the bloodstream. And I remember the video had a little mnemonic to help remember this. No I in ester, ends in one I-like sound, like procaine.
That's a great memory aid. Now, amides, on the other hand, are metabolized primarily in the liver by a group of enzymes called microsomal enzymes. It's a more complex process than with the esters.
Okay, so liver for amides. And the mnemonic for those was amide has one I, ends in two I-like sounds. Lidocaine, bupivacaine, articaine. Esters, quick breakdown in the blood. Amides, liver is the main player.
You got it. And this difference in metabolism is really important because it can have implications for how these drugs are used. For example, someone with liver problems might process amides more slowly, which is something a doctor or dentist would definitely need to consider.
Right, we're talking general principles here, not giving medical advice. But it highlights how important understanding metabolism is.
Absolutely. Now, the material also pointed out some interesting exceptions to these general rules, like prilocaine.
Yeah, prilocaine stood out.
It's technically an amide, so most of its breakdown happens in the liver, but prilocaine also gets metabolized in the lungs to some extent.
So it's got a two-pronged approach.
Exactly. And what's really important to note here, and the material stresses this, is that at high doses, prilocaine carries the risk of causing methemoglobinemia.
Oh, well, that doesn't sound good.
It's a condition where the hemoglobin in your red blood cells can't carry oxygen effectively. The video even calls prilocaine the criminal in this scenario when given at high doses. It's definitely a safety concern to keep in mind.
Okay, noted. And then there's articaine, which seems to be the rebel of the group, metabolized in two places.
Articaine is fascinating. It's classified as an amide. It has those two I sounds we talked about.
Yeah.
But its structure also includes a thiophene ring, which has an ester group.
So it's like it's got a foot in both camps.
Exactly. And because of this unique structure, articaine gets metabolized in both the plasma, like the esters, and in the liver, like the amides.
Double duty. That's why the video highlighted it as being popular for longer procedures, right? It hangs around longer, providing that numbness.
That's exactly right. This dual pathway gives it a longer duration of action, which makes it a go-to choice when you need extended pain control. Think of articaine as having a double agent status in your body. Its dual breakdown means it gets a longer mission, providing sustained numbness exactly when it's most needed for those more involved dental procedures.
Okay, so we've covered the drugs themselves, how the body handles them. Now let's get into that little cartridge they use at the dentist. There's more in there than just the numbing agent, isn't there?
Oh yeah, it's not just a solo act. The material you sent breaks down all the key players in that little tube.
So starting with the star of the show, the local anesthetic itself, they usually list the concentration as a percentage, right?
Yep, that percentage tells you how much of the drug is in the solution.
And the video did a helpful little calculation. For a standard 1.8 milliliter cartridge of a 2% solution, that works out to be 36 milligrams of the anesthetic.
Which is important to know, especially if you're dealing with a different size cartridge. Like a 2 milliliter cartridge would have 40 milligrams of a 2% solution. Those percentages are crucial for figuring out exactly how much drug is being administered.
Right, dosage is key. Okay, so what else is in there? The material mentioned a vasopressor drug, like epinephrine.
Epinephrine. It's often included, and for good reason. Remember how we talked about vasodilation, those blood vessels widening? Epinephrine counteracts that. It helps constrict those vessels back down.
Right, so it's like the body's natural, let's tighten things up signal.
Exactly. And by doing that, it brings a whole bunch of benefits. It reduces blood flow to the area, which means less bleeding during a procedure. It slows down the absorption of the anesthetic into the bloodstream, which lowers the risk of toxicity. And because the anesthetic stays around longer, the numbness lasts for a longer period of time.
So it's about safety and effectiveness.
It's a win-win situation. But there's a catch. Epinephrine itself can be a little unstable.
Prone to degradation.
Exactly. That's where sodium bisulfite comes into the picture.
Okay, sodium bisulfate. Tell me more about this unsung hero.
Sodium bisulfite is an antioxidant. Its job is to protect the epinephrine from oxidation, which is a chemical reaction that can make it less effective over time.
Now, it basically takes the hit for epinephrine.
It's the sacrificial lamb, ensuring the epinephrine stays potent. However, the material did point out that this can be a bit of a double-edged sword. As the sodium bisulfite does its job, it can lead to a slightly more acidic pH in the solution.
And that could be the culprit behind that burning sensation some people experience when they get the injection, especially if the cartridge is older.
That's right. And on top of that, the presence of the vasopressor itself, like epinephrine, also contributes to a lower pH compared to solutions without it. And importantly, the material emphasizes that some people are allergic to bisulfites, which would make using a local anesthetic with a vasopressor a no-go for them.
Right, allergies are always a factor to consider. Okay, what else is in the mix? Sodium chloride was mentioned.
Sodium chloride is just good old salt.
What's salt doing in there?
It helps make sure the solution is isotonic. That means it has the same concentration of salt as your body tissues.
So it doesn't mess with the natural balance of things.
Exactly. It helps prevent discomfort or damage to the cells at the injection site.
Makes sense. And then there's just plain old distilled water.
Good old H2O. That's the diluent, the stuff that provides the volume of the solution. You can't inject pure concentrated drug. It needs to be in a suitable volume for administration.
Right, it needs to be spread out a bit. Now, the material also briefly mentioned methylparaben, but it's not used anymore. What was the deal with that?
Methylparaben used to be added as a bacteriostatic agent, which means it prevented the growth of bacteria and fungi in the solution.
So a preservative.
Exactly. But then dental cartridges became single-use, which meant there was less need for a preservative. Plus, there were concerns about methylparaben potentially causing allergic reactions, especially with repeated exposure.
So they decided to ditch it.
They phased it out, and honestly, for good reason. It's an excellent example of how the formulation of medications can evolve based on safety considerations and changing practices.
Okay, so even seemingly small changes have a reason behind them. Makes sense. Now let's talk about things that can go wrong with the cartridge itself. The video mentioned bubbles. Should we be worried if we see one?
It depends on the bubble. A tiny bubble, like 1 to 2 millimeters, is actually normal and nothing to be concerned about. It's usually nitrogen gas.
Nitrogen gas? Why would they put nitrogen in there?
It's there to protect the vasopressor. Oxygen can degrade the vasopressor, making it less effective. So that little nitrogen bubble acts like a barrier, keeping oxygen out.
Ah, so it's actually doing a good thing.
It's a bodyguard for the epinephrine. Now, if you see a big bubble, like bigger than 2 millimeters, and especially if the rubber stopper at the end looks pushed out, that's a problem.
That's the extruded stopper the video talked about, right?
That's the one. That generally means the cartridge has been frozen. And you never want to use a frozen cartridge.
Why not? What happens when it freezes?
When the solution freezes, it expands, which pushes that stopper out. And more importantly, freezing can mess with the sterility of the solution.
So it might not be safe to use anymore.
Exactly. The material also mentioned that if you see an extruded stopper, but without a big bubble, it could mean the cartridge was stored in a disinfecting solution for too long, which can also cause contamination.
Okay, so big bubble or push-out stopper, just toss it.
Better safe than sorry.
And finally, let's talk about that burning sensation again. We covered the pH and the vasopressor, but were there any other reasons mentioned?
Yeah, there are a few other possibilities. Some people are just more sensitive to the normal pH of the drug itself.
So individual variation.
Exactly. Also, in the past, if the cartridge wasn't handled perfectly and some of the sterilizing solution got mixed in with the anesthetic, that could cause burning. But that's less of an issue now with single-use cartridges.
Makes sense.
Overheated cartridges could also be a factor, although that's less common. But, as we talked about, the main reason for that burning feeling is usually the lower pH of the solution, often due to the vasopressor and the antioxidant.
So it's a bit of a trade-off for those benefits we discussed.
Right. You gain longer-lasting numbness and reduced bleeding, but you might experience a bit of a sting.
Fair enough. Okay, last but not least, how long do these things actually last? How long does the numbness stick around?
That's a crucial question, and the answer is, it depends. The duration of action varies depending on the specific local anesthetic used, and importantly, whether a vasoconstrictor like epinephrine is included.
The video is really clear about that. Epinephrine extends the show.
It does. It makes the numbness last longer, both of the tooth itself and the surrounding soft tissues.
And they talked about different categories based on how long they typically last, mentioning mepivacaine and prilocaine without a vasoconstrictor as having a shorter duration.
Right, those are considered short-acting. And the material emphasized that dentists really need to consider the anticipated length of a procedure when choosing which local anesthetic to use. You wouldn't want the numbness wearing off in the middle of a complex extraction.
That would not be a good time.
Not at all. So the choice of anesthetic depends on the type of dental work being done and the individual patient's needs. It's about tailoring the approach to the specific situation.
Okay, we've covered a lot of ground here. So, for our listeners, what are the key takeaways from our deep dive into the world of dental local anesthetics?
The most important thing to remember is there are two main types, esters and amides. And the big difference between them lies in how they're metabolized. Esters break down in the plasma, amides in the liver.
And we can't forget the vital role of those vasoconstrictors like epinephrine. They make those anesthetics work better and safer by keeping those blood vessels from getting too wide.
And every other ingredient in that little cartridge has a specific purpose too. We've got the antioxidant protecting the vasopressor, the sodium chloride making sure the solution is compatible with your body, and good old water providing the volume. They're all part of a carefully balanced formula.
And knowing about potential issues with the cartridge, like weird bubbles or that pushed-out stopper, can help you make sure the anesthetic they're using is safe and effective. Plus, understanding why you might feel that burning sensation can put your mind at ease.
It's all about being informed, right?
Exactly. So even if you're not exactly thrilled about getting numb at the dentist, this deep dive hopefully sheds some light on the bigger picture. It's a reminder that medications are carefully designed, our bodies handle them in complex ways, and even those seemingly minor ingredients and storage conditions can make a big difference.
Absolutely. It also raises an interesting question. If something as seemingly simple as a local anesthetic involves such precise formulation and different metabolic pathways, what other everyday medications might have complexities we never even consider?
Or, if something like freezing can affect a medication's safety, what other seemingly harmless factors might be influencing the drugs we use every day?
It's definitely something to think about.
It is. Thanks for joining us on this deep dive into the world of dental numbness. Hopefully you've come away with a whole new appreciation for that little shot at the dentist.
And maybe a little less fear next time you're in the chair.
And maybe, just maybe, a newfound fascination with those seemingly simple medications we often take for granted.
You never know where that curiosity might lead you next.
Exactly. That's the beauty of deep dives. You never know what you'll discover.
Until next time.
See you then.